Okay, good morning and good evening to all the participants in the ICC. I'm very sorry for the technical error in the very beginning to welcome Professor Millesi. Dr. Gabriele Millesi graduated from medical school, University of Innsbruck in 1987, then complete her residency training in oral and maxillofacial surgery at the top department of Craniofacial surgery, Medical University, Vienna, during 1987 to 1994. Besides, Professor Millesi graduated from Dental School, Medical University, Vienna at 1992. Since 1995, Professor visited many surgeon masters in the world, including Professor Ralph Millard, Professor Fernando Ortiz, Monasterio, and the Mission Southern Smile at the San Jose. And then in 2018, come visit the Professor Yurei Chen in Chang. Professor Millesi received honorary fellowship of the AAOMS in 2021 and has been the president of the International Association of Oral and Maxillofacial Surgeons, IAOMS, during 2020 to 2021. Professor's main activity is the orthodontic surgery, pre-prosthetic, and oral surgery, and has been recognized as the author and the co-author of the multiple articles in national and international journal. Today, we are so honored to have Professor to come share the topic influence of digital workflow on surgical treatment protocol in OGS. And this presentation will be paneled by four of Professor's good friends. Professor Choi from Korea Asan University, Professor Wu from Taiwan Veteran General Hospital, Dr. Lin and Dr. Yao from Chang Memorial Hospital. Finally, let's welcome Professor Millesi's talk. Professor, please.
Thank you very much for your kind words, Tanya. And I have to apologize first for this inconvenience, and I hope that I can still keep you in joining me, because I'm very enthusiastic that I can give you this lecture and that I can participate in your international webinar series, the Chang'an Hospital. Thank you for inviting me, and a special warm welcome to all my Taiwanese friends and all attendees, and especially, of course, to the esteemed panelists, all good friends. I'm very happy to have you with me. Unfortunately, I cannot see you. You know, we're all suffering from COVID and all these travel bans. It's just a nightmare for all of us, but at least we can share some of our knowledge. So today I'm talking about the influence of digital workflow on the surgical treatment protocol in orthodontic surgery, as Banyu mentioned already. And I also want to highlight that we had the great opportunity to visit Chang'an Hospital and Professor Ray Yu Chen in 2018, and I'm very happy that we have this relationship and that I can be with you again now. Just for those ones who don't know where I'm working in the General Hospital of the Medical University in Vienna, which is a big hospital, as you can see, and there I'm exclusively doing orthodontic surgery. So talking about the digital workflow, I want to start my presentation with a little thought. Did you ever consider how our great predecessors like Hugo Oppegieser or Paul Tessier, all these big shots, how they came up with their innovative surgical techniques and great results without any of those advantages of the three-dimensional tools we are having today? This was only possible because they had great experience, long learning curves, besides their technical skills, of course. But that is exactly where I see the big advantage of all our digital planning and virtual imaging, that we can speed up our learning curve and that we can share our know-how with our mentees and our residents and our next gen. So that is a big advantage, because And we can even do it from home. You know, it has become such convenience that you can do it at home from your table if you have the access to DICOM data of a CBCT or a CT or an STL file of the occlusion. And then, of course, you need some planning software like the Dolphin or whatever. All these software programs are excellent. I'm using several ones. The majority I'm using Dolphin, in fact. And then if you have a printer, you can even do the CAD/CAM Splint yourself. So this has become very, very convenient. Ideally, I prefer to have an IT with me, an engineer. So we are in a team. They prepare everything for me. So the table is set more or less, and I join the team viewer session, and then I do my virtual planning. So that is how it works. Here we have a patient, a Mongolian lady, as you can see, a collegial class 3 patient. And even if we talk about all the advantages of 3D virtual planning and all the digital workflow, for me, it is very important, especially for younger attendees who are joining us today, to tell you have to examine your patient still. This is goal number 1. You have to talk to the patient. You have to see the smile. You have to see how they talk. This is the first answer to a good treatment plan. And as you can see here, it starts with the natural head position. Of course, that is very important because if you look at the steps on the left side, you see that's the wrong position of the patient. In fact, she has an open bite, and it's mandatory to see the natural head position because in treating an open bite, you have to know where is the problem. Is it in the maxilla or is it in the mandible? So to transfer the natural head position into the CBCT, we use radio opaque markers. We mark those ones in 2 planes, and we project these with a laser beam into the CBCT to have the correct head position. And just to give you a little glance, this is a Japanese lady. I just recently did surgery. If you go fast from one to the other, I don't know whether you can see it, the little change in the head position gives you a wrong impression what is needed. She's a patient with a hemimandibular elongation on the right side. So what she needs, and I'm afraid all the videos are not working because that is also something I experienced already with Zoom, that it's not working. She needs an impaction, especially on the right side, and then a rotation and a correction of the midline to get a good result. For a long time, I had a problem because we were talking about digital planning, and in fact, we always still had to do casts, impressions of the occlusion, and transfer this occlusion into the CBCT or the CT. So that was not fully digital, but now it is fully digital, and that is a nice paper from Chang Hospital, and I want to mention it because you compared the 2 versions, the conventional one with cast to the digital occlusion we are working now with the intraoral scans, dental occlusion. And the outcome is absolutely accurate in both ways. So that is a major step we achieved in the last years. And you can check this occlusion. You have exactly, this is again our Mongolian lady, we see an overloading in the premolar area and canine area. So then by only rotating the mandible a little bit, I know exactly that I get a good balanced occlusion. And that has become so convenient. Additionally, of course, you have additional information in regards of corrections of ostectomies. If you look at the mandible here, by setback of the mandible, but still, again, the experience of the surgeon is coming in because you have to know that this is a 3-dimensional body, and what you have to resect from the lower border is not the same amount you will have in the crestal area. Therefore, you see the difference in the little bony fragment on the very right side. So this is again experience of the surgeon, and if you lay a layer of in your virtual planning, you will see that it differs. The other information you get is if you do 3D virtual planning, that you know you will have interferences. If you rotate the mandible, you might see gapping, and on the other hand, you might see some interferences which need to be corrected and resected to get a balanced position also of the condyle and not tilt the condyle. And there's a very nice paper by the Spanish group around Federico Hernandez Alfaro, because they experienced in their study group that whenever you see interference in your software program, in your planning, it is not necessarily always interoperatively. Whereas the other way around, whenever you see it interoperatively, it will also be already in your planning. But there is a difference because, of course, the software programs, they have a defined cut, and this is not adapted individually. So therefore, there might be a little change in reality. And that is, again, something where the experience of the surgeon comes in. And where we still all struggle is our soft tissue prediction. In the profile, it's pretty good, but in reality, here you see the lady after surgery, but in reality, on fast view, we still have the problem that this is not really that you can rely on. And you have to tell the patient, especially if you do surgery first, where you have not aligned dental arches, as in this patient here, you see we have to advance the maxilla more than we see in the prediction, or we would consider it good in the prediction, because we will lose again protection of the upper lip when those proclined incisors will be moved back by the orthodontist. So that's again something that's a multiple piece maxilla, and in those ones, any soft tissue prediction is very difficult. We also published this in a paper where we tried to figure out accuracy in soft tissue prediction in surgery first cases. And then those ones with multiple piece maxilla, those predictions were the least accurate. So we have to know this and we have to realize. Coming back to the digital planning of the final occlusion, I think there's another major jump into the future, because it has become really accurate with our treatment plannings and also the orthodontic procedures. Here again, we have a patient with a long face. We see characteristically for Caucasians, we see the collapsed maxilla. If we plan a three-piece maxilla, tighten the maxilla, this surgery early, patient had already a little bit of orthodontic treatment. Then we do the software program with segmentation and create a dental arch. We know exactly, as we mentioned before, where we have super contacts and where we have to reduce a little bit. And that is the proof that it is correct and that we were able to fulfill our mission. If you look into the situation intraoperatively, we see the ostectomy, the impaction of the maxilla quite severely, as it's a long face, and then a premolar extraction, and through the socket of the extraction, there was the vertical cut of the segment. And the proof that this has been done properly is that our CAD/CAM splint really fits for the dental arch. Then I know I did the right thing. I always stabilize the segments, of course, as you can see. And here you can see, when we do our planning, we have to be aware that we cannot only orient ourselves by the dental arches, although we would like to approximate the molar segments as much as we can. But you have to look at the shape of the roots, you have to look at the angulations, and then you will know that this is unrealistic if you approximate the crowns too much, because you will hurt the roots and you might lose teeth if you do it. So you have to concentrate on the anatomy. This is what the surgeon does, of course. So our orthodontic partner concentrates on the dental arches. So look at this estimation of the future occlusion. There is no gap anymore. But this is, of course, because the orthodontist is lacking this information. We know from practical work in the OR. And that therefore, it's major important that you always check the suggested occlusion of the orthodontist as the surgeon, what I always do. So here is our patient. That is the patient 2 months after surgery. You can see there's a good alignment, and now he's in sure smile, and it's only a question of time that he is finished. In a surgery first case, as this lady here with the hemimandibular elongation on the right side, you see there is severe crowding, and to check the occlusion, I always contact my orthodontic partner, because he or she is the one. It's more she. I select my colleagues and my partners in orthodontics where I do surgery first. That is very important. And we have to check the occlusion together. So because the orthodontist and the surgeon, we are a team, and we have to do it together. So the orthodontist will do the first simulation of the occlusion in SureSmile. And that is again where we have the next digital step, SureSmile. So here she can tell me, yeah, it will be possible. We can do surgery first. And that is, where we decide, where are we going? Do we do orthodontics first, conventional, or is it surgery first? And most of my cases are surgery early now. I also learned, I would say, surgery early is my favorite now. And here is our lady again, and you can see before surgery, she gets bonded, she gets individualized braces, and the intraoral scan is done and used with the CBCT. And this is the piggyback occlusion that the orthodontist is trying to do. On the left side, the original, on the right side, the piggyback. And again, only by the tilting of the chart, you see that the orthodontist, of course, she does not see what the real skeletal situation is because we have a tilted occlusion, as you can see on the upper screen. And that is how our treatment plan is designed. You see a major impaction on the right side because we have to correct this tilt. And then, of course, we have severe midline discrepancies, and she needs an asymmetric genioplasty as well. Again, situation during surgery, you see more ostectomy on the right side than on the left side, and then the rotation of the maxilla fixation, the CAT-CAM scans. And then in the mandible, again, the rotation, you have some gapping on the right side, which is important that you don't get too much compression on the condyle. And on the left side, we have gapping in the buccal aspect, and that needs augmentation. And then the patient always, those hemimandibular elongation cases, always need an asymmetric reduction genioplasty to achieve symmetry. This is the fusion of the dolphin planning with the intraoral scan. And then this simulation is taken to SureSmile, and the orthodontist already gets the pre-bent wires, and the patient gets those wires already installed so that after surgery, there is a directly continuity in orthodontic treatment. And this is those robotically assisted archwires. This technology definitely is an advantage. We try to do this as much as possible now because it's again another speed up in treatment protocol. And that is a nice publication also with the hemimandibular elongation case, and that's why I want to share it with Nanda and Gabriele, and they also used SureSmile wires already in 2015. And here's our patient again, 3 months after surgery, treated with SureSmile. And then this is the patient. She had surgery in July 2020, and you see, as you can see on the right side, debonding March 21. So it's 8 months overall treatment. Very fast and effective treatment. The recessions were, by the way, already from former orthodontic teens. So already some orthodontic treatment in Wayne when she was a kid. Talking about digital planning and the transversal discrepancy. We are really suffering with our Caucasian patients. We have a lot of collapsed transversal width and collapsed maxilla. I think you don't know that problem with the Asian patients because you don't see that too often. But this is a major problem in our patients because it means recurrence if this is not treated properly. So SARPI was the treatment protocol, I would say the standard treatment protocol some years ago. But there are additional ways to do it because SARPI means second procedure, and this is really not very advantageous for the patient. So how do you do it then? I strongly believe in extractions of premolars if you have such compromised maxilla with long dental arches. There's a lady with a class 2, a severe overchat, as you can see, and the long maxilla. So again, coming back to our SureSmile planning, We have a CT. We know that this is impossible to do a segmentation. Look at the angulation of the roots. Premolars have to be removed to do a safe segmentation. This is one aspect. And the other aspect is that you see there's a very small distance between the two canines. So if you try to come up with a surgery first occlusion in a patient like this, you would have to do an additional midline segmentation. I did this also, of course, but if I can avoid it, I try to avoid it. And if you start with some minor orthodontic treatment before something like 3 months, it is possible to avoid. And that is the situation then. In the middle, you can see premolars are out, and the orthodontist has already done some alignment of the frontal segment, and then the patient needs a correction of the vertical axis and the segmentation for transversal widening. And this is the outcome. 1.5 years after start of orthodontic treatment, and after surgery, after all, the bonding after 1.5 years. And she has a very nice aesthetic and stable occlusion now. Again, coming to those compromised maxilla, and I want to highlight with this patient here, he had already treatment when he was a teenager, and look at this compromised maxilla and this open bite case, long face patient. So in 2006, when the boy was 16, he had orthodontic treatment, and the result was that the orthodontist was able to expand the arch, as you can see on the left side. But this is not stable, and this is exactly what I want to highlight. In those cases, you can, by doing extractions and advancing the molar segment, you can create very nice, stable, anatomic dental arches. And that is major important, especially in open bite cases, because otherwise you see relapse. And in addition, of course, this patient was now treated at age 30. As you can see, there was, again, vertical growth in the molar segment. So that is why this patient needs a correction of the skeleton to achieve a stable result. And that is exactly going back to our very, very early publication by Berman and Berman, when they first wrote about open bite cases treated with surgery first approach in 1988. This is exactly what we see. We have this anatomical skeletal axis, and that has to be corrected. And that is what we have to plan in a patient like this. So here I want to separate it. Once what you do as a surgeon, and once what the orthodontist does. And we start with the orthodontic planning, the surgical planning. My orientation primarily, of course, is aesthetics. I honestly have to say, because that is what the patient also cares most. You all know this. With, of course, good function. That is for sure, too. So what this patient needs then is a severe impaction of the maxilla, and we need expansion. Look at this narrow maxilla. And that is what is planned, as you can see on the right side, impaction of the maxilla and severe advancement especially. Because I cannot do too much impaction because the patient has a long upper lip. That is, we have to be cautious about this. So what he needs is advancement especially. And this is, look at the numbers. That is quite a severe advancement. So it's approximately 10 millimeters in the A point and a little less 9 in the incisor edge. And then even for the molar segment, it's more because we have this ostectomy in the socket of the. Can you still hear me? By the way, is everything okay?
Yes, no problem. Please go ahead.
Yeah, okay.
Professor.
Okay.
Yes.
Good.
Yeah.
Yeah. So it's even more in the molar segment because you see this has to be advanced anteriorly. So that is quite a task if you do this. And again, as you can see, it needs fixation of the segments. This is very important. And it needs very cautious mobilization, of course, of the segments, especially if you advance the maxilla so much. There's a lot of tension on the pedicle. But on the other hand, if you have such a high wound, you see that by impaction, the tension on the palatal pedicle is again decreased a little bit. So here we see the planning, again, as I mentioned, don't concentrate on your teeth only, but you have to see the the socket, you have to check the alveolar bone and the angulations of the roots. And then you know that you cannot adapt it totally because otherwise you injure your roots. And here, those gaps need to be grafted. This is also very important. Different ways to do it. You can either collect the bones, you can grind it in a molar, in a mortar, or you can use a bone collector. Then you have already a very nice little, very soft sausage of bone, and you can put it into the segments. This is very, very, very nice. Yeah. So here is the patient in the profile, the predicted profile, as you can see, and on the right side, the patient directly after surgery with the profile. Now everyone has these bars over the noses, COVID times, that's a COVID victim. He has to wear a mask when those pictures are taken and these scans are taken. So, and that is the patient. 3 months after surgery, a severe difference in his appearance, and also if you look at the width of the maxilla, that is a very nice and stable width, and it will not change within the next years. I know this for sure, if I do an extraction and expansion. Coming to our orthodontist, as I mentioned, the orthodontist tries to make a sure smile prediction and simulation of the occlusion. And the segmentation is given by me because I tell the orthodontist we need a segmentation in this case. So here you can see the orthodontist orients herself by my information. And then we start with extraction, premolar extraction, and wisdom teeth are removed. And then she does a little alignment, primarily only to expand the distance between canine and canine, because that is sometimes too small, and to avoid additional midline vertical segmentation. But the orthodontist comes up with the piggyback occlusion, and this piggyback occlusion is oriented on my designed maxilla already. But then, as you can see here, of course, the orthodontist does not take in regard that here we would have too much tilting of the condyle on the left side. That is not possible. So we have to harmonize the occlusion. We have to find a compromise between my occlusion and the orthodontic occlusion. And then, so we adapt, rotate the mandible a little bit and find a compromise that is fitting for the orthodontist and for me as the surgeon. And again, this is the patient then, the occlusion, 3 months after surgery. And now the patient is already in sure smile wires and gets the fine tuning. And within 5 months, he will definitely be done with a major procedure, I would say, and a severe correction. So I cannot talk about digital planning without mentioning the new tools, new hype about splintless surgery. And I think this is the word and this is the procedure that is right now done everywhere. It's a big hype. And as it's costly, in my hands, we have to make a clear indication to do it. And I think the indication to use individualized plates is in a patient where you have severe advancement and downwards movement for stability. And that we know from the hierarchy of stability that these are the least stable procedures. So in those cases, individualized plates are fantastic, especially in short face syndrome patients. As you see here, this lady here, that's aesthetically a catastrophe, and of course it needs a clockwise rotation and severe advancement. And as it's a class 2, we have to start with orthodontic treatment so that we can get a proper advancement of the mandible afterwards. So this is the patient, the simulation. She had orthodontic treatment before surgery. And then if I do a 3D planning for individualized plates, I know exactly how much I have to advance the maxilla. And I know that this needs grafting. This needs grafting, 9 millimeters, 10 millimeters, it needs grafting. Otherwise, it's not stable, even not with individualized plates. Here you can see it. This is the individualized plate. And I have the donor bone in place already. And which cutting guides you're using, whether you're using titanium cutting guides or resin-based cutting guides, They are both good. The titanium are more expensive in general and more stable, but both are actually usable. And this is the outcome, and the outcome after 2 years. And as you can see, and also from the smile of the patient, we are not only changing faces, but we are changing lives. In those patients, we can really achieve good results using individualized plates. And there is another big advantage in using individualized plates in those patients, because as I was taught to do maxilla first, and I always do maxilla first. We know that in those cases, they have a very difficult and unpredictable position of the condyles and difficult reproducible. So if you're using splints for defining the position of the maxilla, you are not quite sure whether that is the really accurate position of the condyle. So in those cases, if you use individualized plates, you're absolutely independent of any condyle position. So the maxilla will be where you want it to be for your aesthetic consideration. And that is a big advantage. Here you can see this is quite a change in the position, a counterclockwise, clockwise rotation of maxillomandibular process. You can see there's a nice adaptation and remodeling of the mandible, as you can see in the CT. This was taken 2 years after the surgery, and this is very convenient if you do it with individualized plates. Nevertheless, there are also traps, and you have to know this as surgeons, because if you cannot trust them without considering your steps. Because of course, for example, when you design your cutting guides, you can already define the angulation where you want your vertical cut in the segmentations. That is one point. And that is something you have to say, not the technician, of course. So if I do any of these individualized plates or implants, of course, I am the one who tells the technician what to do and where to be careful, because the technician is not able to know what is the situation intraoperatively. And also, in those rotations, clockwise rotation, you will have some interferences in the retromolar area. And that is, again, the individual task of the surgeon to remove these interferences to get a very smooth position of the maxilla. In rare cases, like, for example, this lady with the Golden-Gall syndrome, that is also a very good task to use individualized plates, because this was a progressed syndrome case. As you can see, multiple cysts, destruction of the maxilla already in the molar area on both sides. So it's very tricky to find a proper stable position for the osteosynthesis later on. As the patient had a class 3, I decided to do a level 1 osteotomy, which was ideal to get good access to the cysts. And here you can see the CT, the CT scans, and you see that there is really limited bone which can be used for stabilization. So the cysts were removed, and then this was the designed plate, which was done before surgery and individualized. And the cutting guides, resin-based in her situation. And this is ideal for in those complicated cases as well. Then in other cases where you need implants, for example, and you use your 3D planning. This is a hemifacial microsomia case. The boy, the young man, had already a Bimax to correct the asymmetry and the tilting of the occlusion. And nevertheless, according to the syndrome, of course, there was a severe lack of angle, of the bony angle, and the lower third of the face was still very asymmetric. So he needed a genioplasty. And then I decided to do a titanium implant for the angle. On the screen, we know what we want, because I know exactly what the patient would need in regards of symmetry. But of course, sometimes it is just very difficult that you're able to achieve it. And in this situation here, as you can see, I had these individualized plates, but I was too ambitious and too courageous that I could achieve this position of the genioplasty, and I had to adapt the plate afterwards a little bit because there was just too much muscle tension to achieve this original goal. Nevertheless, luckily, the outcome was acceptable and the patient was happy with the outcome. But you have to be cautious about, are you able to achieve this result? In our department, at the University Clinic in Vienna, already 25 years ago, my former chief, Professor Evers, he was a visionary in all new technology, and so we were already 25 years ago, we were using navigation and augmented reality in the field of oral and maxillofacial surgery and craniofacial surgery. So this is somehow our heritage, and talking about new technologies, I want to mention that we were also able to participate in the first in-man study with Carlo, which is a cold ablation robot-guided laser osteotomy. This was a cooperation with Basel, University Basel in Switzerland, with Professor Zeilhofer and Professor Philipp Jürgens, and also with Hamburg. And we did 14 patients, orthognathic cases, with this Carlo. It was the first in-man study. This is the technology you need for this is you have, of course, a 3D virtual planning. You have to register this. You have to fulfill all the tools of navigation. And then you have this roboter that gets this information. And then the ethics approval was only to do the vertical cut for this study. So we had to start with something. So it was the vertical cut for the osteotomy. And unfortunately, the video is not working, but it would be impressive because it sounds like a machine gun when the laser is going through. And in contrast to Da Vinci, you are on the table, so you can stop it at any moment when you want. And there are a lot of future aspects in doing it. We, in our series of our 14 patients, we were only able to do the horizontal cut, but for the future, of course, there will be more possibilities to use it, not only in craniomaxillofacial, but also neurosurgery, of course. We also published our first experiences with Carlo. As you can see, our first in-man study. And to finish, I want to show you one patient. This is one of our patients from the study group. He had a severe open bite, and he needed a bimaxillary procedure as well as a midline osteotomy. And this was achieved successfully without any complications. And luckily, also the other patients had no complications. So there are future aspects how you can use it. The ideal would be you create different patterns, like different sinus curves, that you can just, according to the sinus, you can advance the maxilla. You might not need as much osteosynthesis anymore. But there are a lot of future aspects that will be coming up in the future. So concluding, I want to say that, of course, with all the new technology and the digital planning, we are all heroes on the screens, but we have to be careful that we have to execute it safely and accurately in the operating theater, and there will be more new digital tools and results to come. So thank you very much for your attendance. It was my dear pleasure to be with you, and I hope I could give you some interesting aspects. Thank you very much.
Thank you so much for the very educational lecture. And now, before we go to Q&A, we would like to invite our panelists for a few comments. And first of all, we would like to invite Dr. Choi, Professor Choi.
Hi, Gabriele. It's been a while.
Hi. Nice to see you.
Yeah, nice to see you.
Your book is really.
Yeah,
your
so
book
I'm really
is next
happy.
to my bed. You're such your
Yeah.
first book.
Thank you so much. So first of all, thank you for the sharing your experience beautifully in terms of how to apply the digital surgical planning, including the surgery first in the very complicated cases. So Can I ask one thing? So you have shown the many your ways how to overcome the problems such as the open bite and the transverse parietal problem when we apply the surgery first. So among the various obstacles, which factor would be the most difficult one when we apply the surgery first orthodontic approach, according to your experience?
I think, well, there are hardly any restrictions where you can say, no, this is not feasible in surgery first. We all know class 2 is a no-go because you need the proclining of the upper incisors, otherwise you cannot approach the mandible properly. And that is also the same in older patients then. If you have older patients, which we more or less try to keep the occlusion the way it is, but if it's a class 2, then we have to say we have to achieve as much advancement as possible, so we need some orthodontic treatment before. Otherwise, I think, and actually I would be interested to hear your opinion too, because, you know, we in our Caucasian patients, we have a lot of struggle with the transversal width. And I think you don't see this in Asian patients. I have even Asian patients where I have to reduce the transversal width, which is never in a Caucasian. But if you don't treat the transversal width properly, you will have relapse. And this is something I would say not every orthodontist understands properly, because they believe they can open and expand in all dimensions and it will be stable. And it's not just not stable, because the teeth are not stable. And therefore, I believe that is the case where we really have to change the anatomy of the upper dental arch by doing extractions and reducing. But of course, you're right. You have to explain your patient that, number one, you have to extract teeth. There are patients who are not very happy when you tell them you extract a healthy, maybe premolar. So that is one point. And the other point is then, of course, that doing segmentations is maybe more risky. You have to explain your patient that if they prefer to have a SARPI, for example, then you could also achieve it, but the final result, but it's just a question of time. And in general, it's 1 year more.
Right.
And there are also not many surgeons, at least not in Austria, not many surgeons who are really willing to do segmentation.
Right.
So I think it is tricky, and I have to say that, of course, you have to always to be cautious. And I don't do it in patients with compromised periodontal health, and not in patients who are smokers, because this is a problem. You might see a problem, and you might see that you lose teeth. Yeah. So these are patients where I would say, okay, we do SARPI, we don't do segmentation.
Yeah.
But otherwise, sorry, I will stop in a minute. But I think it's also very important that you have an orthodontist who understands what you are doing and who is reliable. Because if you have an orthodontist who feels overwhelmed and not able to finish the case, you have to be careful. It's better you do it conventional, you don't do surgery first.
Yeah, Gabriele, so thank you for your answering, including the very details. Thank you.
My pleasure.
Yeah.
And for our next panelist, we would like to invite Dr. Wu.
Hello, Professor Millesi. Nice to meet you again here in the internet. And I would like to congratulate of your work on the digital workflow on the orthodontic surgery. And you also demonstrate many difficult cases and how you solve the problem by digital way. And I also show see you use the Splint technique in some cases, And you also mentioned about the maxilla first approach is your favorite, almost in every cases. And especially in the deep bite case, when we do a large amount of clockwise rotation, and sometimes we'll encounter the conductor problem. And even so I would like to know the experience when you use the splint technique. Is it we still cannot solve the problem of the interference inside of the maxilla and from the condyle. So I don't know if there any change from the traditional splint technique if you use the splint-less technique. And the other side, would you like to use the one splint technique if in the deep bite cases, and if we have also planned digitally by splintless technique, would you favor for one splint technique to the deep bite cases? Yeah.
Mm-hmm. Well, thank you very much. Nice to see you again.
Hey, yeah.
I have to say that I always have two splints in bimaxillary cases, but as you mentioned, and this is absolutely right, the most important, even if you are experienced in doing splint technique, you must not trust it without checking additionally. Yeah, because we all know you can use a splint, and then it depends on how you move your mandible. You can distract your mandible to a certain extent. So it might still be that you don't have the correct midline or some shift to one side. So even if I use two splints, I always check the aesthetic after the maxilla is in position. And I think if you are used to one splint technique, this is exactly what you do. So if you do one splint technique, you check the position of the maxilla only by your eye and your aesthetic feeling. And I double check it. I use the splint, but I double check it. And then, of course, I also check the splints. I start with a splint in a habitual occlusion. So I know that if I would do it traditionally, I have to check whether this is the right position. And if you use CBCT, you need also a splint for the CBCT, that you know that you start from the correct position of the condyle. But I think sometimes it's faster, and if it fits very well, and one look and you know it's okay. So maybe a little faster if you have a second splint, but you can do it with one if you're experienced. Not with if you're a young surgeon. I would rather suggest to have a second splint. And in segmented cases, if you're not using individualized plates, you have to have a CAD/CAM splint, because otherwise you do not know whether the segments are tilted. That could also be, yeah. So I think in those cases it's necessary to have a second splint.
Okay. Yeah, thank you. Yeah, for the explanation. Yeah. Okay.
And our next panelist is Dr. Lin.
Hi, Professor. I'm very interested by your inspiring lecture, especially the part of using the laser to do the cut. Because from the literature, we know that there's many centers trying to do some robotic assisted surgery, orthodontic surgery. What do you see in the future that the possibility that we use the robot to do the positioning, the laser assisted cutting of the osteotomy, and then finally we can totally shift to totally 3D simulation combined with robotic surgery. And what do you see in some, there might be some possible obstacles that we have to deal with?
Yeah, thank you very much for the question. Very nice to see you, Clement. Yeah, nice to see you. Well, I have to say, you know, using this Carlo, this cold ablation robot osteotomy, this is the very beginning. This was the first in man study. And at this moment, the way the arm is angulated right now, it would not be feasible to do it complete osteotomy because you cannot use it across the corner till now. And I also believe that maybe there will be more future fields for using this collar than for orthodontic surgery, to be honest. Yeah, I think it's the ideal use in neurosurgery. For example, if you have to position electrodes in epilepsy, for example, where you need to trepam the skull. This is very fast. It would save operating time because you can calculate how deep you can go in, and that's for me right now. This is more the future. Yeah, they're working on using it for the cutting of the mandible. I know. I did not yet do it. Till now, you know, it was also, as it was first in man, it was only approved by the ethical committee to do the horizontal cut. But what is, of course, would be an option is that you can shape your cut. So if you design your osteotomy, for example, in a sinus curve, and you would advance the maxilla according to this radius, it would be a perfect match. So these are little steps that will come in the future, and there will be future aspects. Right now, it's not yet the tool that we can say we can do the total osteotomy with it.
Thank you.
Thank you very much for the question.
Now, last but not least is our Dr. Yao. Dr. Yao.
Hi, Professor Millesi. Nice to see you again. I think it's our.
Hi, Dr. Yao. How are you?
How are you? Yeah, I think the last time I see you in Vienna about 2 years ago,
right.
2019.
Yeah, incredible.
And because of the COVID, we cannot met personally. But for your great lecture, I think you bring us many new things, and I have several questions from your presentation. So the first is that we see you present several difficult cases of maxilla, the big advancement in extrusion, and I saw there is some bone graft material. So the first question is, what's your preferred bone graft source when for the case with big maxilla extrusion and advancement? And second, I saw for a case of hemifacial microsomia, you use a patient-specific titanium angle implant for the reconstruction. So, what else? What else would you consider to use as a patient-specific implant? I mean, the material, like the peak or something else, would you suggest that we can use for the mandible contour reconstruction? So I have these two questions. Thank you.
Mm-hmm. Yeah, thank you very much. Well, in regards of the grafting, I think this is also one of the advantages in our 3D virtual planning, because we know exactly how much bone do we need. Yeah. So in those cases where I have, I know I need about 1 centimeter of grafting, I would refer to a donor side iliac graft bone. Yeah. And I cut it, I can shape it exactly how I want it, and it's. I don't use. I think it's not good to use a second to use a donor site, to open a donor site in the patient. If the quality of the bone for interpositioning is okay if you use donor site iliac graft. I have to say that I also use it for buccal aspects, for example. And I once saw the situation that this donor site bone did not have the stability I wanted when I used another implant, for example, an angle implant, and one of the design screws was in this position of the originally donor site, although there were some years, so some months in between, half a year. And the quality of this bone, it was too soft then. But for intermaxillary positioning, as these plates are really stable, it's okay if you use donor site iliac graft. If I have smaller gaps, of course, we have to do a lot of impaction in many of the cases. So I collect this bone. This is all collected, and then I grind it in a mortar, and then it's like a paste. And then I put it into, especially also if I do transversal expansion. You know, I do this. I think we did some cases together. I don't know whether you remember. I do it parasagittal on both sides, and then I have to graft these sides, and that's the bone where I put it in, and I cover it with some resorbable membrane to keep it in place, and then I use autogenous bone. In regards of the angle, you're correct. The second alternative would be PEEK implants. PEEK implant is not as especially if it's a big one, it's not as heavy as titanium, of course. And you have to try to avoid sharp edges with the titanium, because that might also be, especially if you have a patient with a very thin skin, it might be a problem. So that you get some atrophy over the skin, and then you would need fat grafts to cover it again. But on the other hand, the titanium implants, you have to design it also sometimes in two parts, because it's impossible to put it in one. And I think the match is easier in titanium in those patients then.
Okay, thank you.
My pleasure.
And we're very fortunate to have Professor Low join us today. So before we head to Q&A, I'd like to invite Professor Low for a few comments.
Hi, Professor Millesi.
Hi. Hi.
Nice to see you. And I also enjoy your talk very much. I have 3 questions for you. I would like to hear your comment on this. The first is that I noticed that you use different software for surgical planning, virtual surgery, like Dolphin, IPS, ProPlan. What indication that you use the different software, or just young fellow do that for you?
So, yeah, that's a very good question. I would say for the routine, if I don't use individualized plates, I use Dolphin. And this is prepared by the technician, and everything is set up in the habitual head position, as I mentioned in the beginning. And then I join a team viewer session, and I tell the technician, okay, now we rotate 3 millimeters to that side, and we do that always together. I personally believe that anything you plan, you have to control it as surgeon. You cannot do it. The technician cannot do it for you, because the technician does not know exactly your obstacles you are facing during surgery. So if I do individualized plates, as I'm working at the university hospital, you know, there are cooperations with different companies, and therefore we alter. That is the fact. Yeah. I know, but I can add one comment that nowadays, as this number of individualized plates is increasing, the companies are hiring a lot of young staff, young technicians, and some of them are just incapable to do it. I honestly have to say. I experienced in one case, I was talking to the technician. I told him, you know, we have to do this and this, and now we need auto rotation. And at the end, I found out that he did not even understand what I meant by auto rotation. So I think at that level, it gets very difficult. And I think that's not right. I think the companies should not hire, because they need staff, hire everyone without any experience, because that is our work as surgeons that we sacrifice when it just takes so much longer to explain what we want to do. But the products, in fact, you know, the outcomes, the hardware is very good in all cases, in all companies.
Thank you. And the second question is that, and I also noticed that you use a lot of, so-called high-tech product for example, cutting guide, custom-made plate, like you said, 3D printed tie, or even use navigation during the orthodontic surgery. Do you use this all the material stuff technique for every case, or just select it?
No, you're absolutely right. You know, that's why I wanted, because I know that as there is such a hype, and this is also promoted, of course, by the industry. You know, they want to tell us you have to do this everywhere. But honestly, this is not true. I think we are all good surgeons, and there are some cases where it's a big advantage. As I tried to show, you know, these severe short face patients, for example, where you have these really serious rotations, clockwise rotations of the maxilla. In those cases, it's fantastic if you have these plates, because you're absolutely independent of any position of the mandible. And that is the risky part, because, you know, if you ask a patient like this to swallow, the position of the mandible will be different every time. So how do you orient yourself if you're using a splint? Then what is the right position? So if I decide the position accordingly to aesthetic considerations, I know where it should be, and then I have planned this on the CBCT with the technician, with my plates, then I know that's the correct position. That is fantastic. And I think, you know, as any hypes we all experienced over the years, it will go back again. It will end up for this indication, because that's the indication for these individualized plates. And I see it also at our university. At the end of the year, we run out of money because it's just too expensive. Yeah, you cannot do it for everything. It's 5,000 euro a case if you would use it for every case. It's incredible. You cannot do it. Or it would get so much cheaper. What won't happen? So that's my very honest answer.
Well, thank you. And my last question is that it's very interesting that you mentioned that you when you do two-jaw surgery, you use two-Splint technique, and you would always use do maxilla first approach. This is in contrast with the the traditional concept that for class 3 you may do maxilla first, for class 2 you may do mandible first. Now, recently I also tried to convert back to two-Splint technique, because I used a single Splint technique for many years, and I would like to look at should I when I try the two-Splint technique, I would like to see, at the end of the simulation, I would ask my assistant, okay, show me surgery maxilla first, what kind of position, bone position, and occlusal Splint, and mandible first, what kind of occlusion and intermediate Splint. So I would like to do that to adjust, to select which maxilla or mandible go first. So listen to your talk. You said maxilla first is always your approach. So I would like to hear your comment that when you see, for example, if the maxilla first that produce very augment intermediate position occlusion, you still prefer to use maxilla first, or if the maxilla is weak, okay, then you feel that when you do the mandible, then if that fixation still hold the same place during your manipulation of the mandible. So this is maxilla first or mandible first, seems that very interesting topic. What is your comment?
Yeah, that's a very true question you're asking, or with a plausible question. Let's say it. I was, this is that's the North Carolina approach, the Tim Turvey approach. They also always did maxilla first, and I was brought up like this. I do understand that there are some advantages in some cases where you would do mandible first. But as I'm so routinely doing maxilla first, it's like a philosophy, you know. Luckily, I can achieve quite good results by doing maxilla first, but I see a rationale in doing mandible first in some cases, and I do understand if people say, well, why aren't we doing mandible first? But I never changed it. I feel more comfortable in doing it the other way around. And it's possible. It's definitely possible to do, but you have to be used to doing it, and you have to have some experience, I would say, that you judge that it is right or wrong. And you are right that in some cases then that you have really thick intermediate splints. And that is, in regards of the condyle, you might consider, well, maybe that is not, you're creating a wrong position of the condyle, and creates recurrence if you don't position it, if you use such a splint. It's right. The argument is right. Nevertheless, I think in those cases, then it's important that the final position you create by doing your fixation of the mandible in the second step, I always check the position of the condyle, and I guess that you have some feeling with it already, that you know, well, this is plausible, and that is actually the position. Luckily, I have very seldom a problem that there is a displacement of the condyle, even in the maxilla first cases. But it's, I see your argument, and I know that this is like discussing about philosophy.
Thank you.
It's right. It's right. Yeah.
Thank you.
It's my pleasure. Thank you. Thank you for the question.
And now, Professor Millesi, if you allow it, we have 3 questions from our audience, if you're okay with that.
Yeah, sure.
Okay,
if everyone can hear me like this.
Yes, it's actually perfect.
It's my
Thank you very much.
my first web lecture I do on the phone, but okay.
Okay, so our first question is from Dr. Zhao Wu, and he would like to ask you to explain a little bit further on the piggyback occlusion technique.
Ah, okay. Yeah, that is interesting, because I think, well, I think one secret of success in orthodontic surgery is that you have a close cooperation with your orthodontist. And I know from Chang Hospital that you have a great department there, and you meet and you talk to each other frequently. So that is very important, I think. And of course, the orthodontist has an idea how the occlusion should be at the time they start doing orthodontic treatment. And that is what we call the piggyback occlusion. So they create, independent of the patient aesthetically and skeletal looks like, comes up with a piggyback occlusion. And this piggyback occlusion is then, if I do a 3D virtual planning, for example, I design, as I do maxilla first, I design the position of the maxilla, and then this piggyback occlusion is fused into this planning by the technician. And actually, I could say, well, that's perfect. I will do surgery like this. But as I tried to highlight in some of my cases, you cannot trust what your orthodontist always does, because of course there's a different approach. And I have to check it, still have to check it, whether this is the right way to do during surgery. And therefore, I always double check the suggested piggyback occlusion by the orthodontist, whether I want to do it or not.
Okay, and for our second question, from Dr. Rao, the question is, do you use a Plateau splint to stabilize the segmented maxilla, or only rely on the Archwire and for fixation? If so, for how long?
Ah, you mean after surgery? Wait a minute, I have to change my hand. Okay, that is a good question, because the splint in those patients, they have a splint in, number one, after surgery. And this splint always has a palatal bar it's either made out of resin or as the splint. For example, if it's in an individualized plates case, if it's coming from a company, or if it's from the orthodontist, it's a splint with a metal bar. And this splint has to be in for 3 weeks. And after these 3 weeks, the splint is out, and the orthodontist has already made a TPR, so that directly after surgery, not 1 day without, the patient is not 1 day without any splint with transversal stability. The orthodontist starts working with the TPA and starts orthodontic treatment. That is very important, because even as you saw, even though I stabilized the segments with osteosynthesis plates, there is still some movement, and therefore it's important that they are additionally stabilized transpalatal.
Okay, and for our third question, we would like to invite Dr. Kulabi to ask the question himself. Dr. Kulabi?
Dr. Kulabi, you have to turn on you have demuted yourself.
Thanks, Professor Millesi, for this very informative presentation. My question is regarding the hemifacial microsomia. It is better to reconstruct the condylar process first, or it could be included during the digital manner by a specific patient-specific implant.
The patient I showed to you.
In case of hemifacial microsomia, where there is absent condylar process.
This patient had a normal function in the condyle. Of course, it was disformed, but he had a normal function in the condyle. It was only a deficiency for aesthetic reasons in the angle, and therefore he got this titanium implant. But the function was normal, and it was only for aesthetic reasons.
Thanks, Professor. But my question, if there is condylar absent, missing condylar process, it's better to reconstruct by autogenous bone graft using costochondral graft first, and later on using the digital manner and a patient-specific implant to reconstruct the condyle by titanium material.
Thank you for your question. Those patients who need reconstruction of the joint and the condylar process, I don't treat those ones in our clinic. They are not referred to me. Therefore, I cannot tell you they're done by another colleague.
Thanks very much, Professor. And thanks for college for giving me this chance to ask. Thanks very much.
My pleasure.
Okay, so we have one more question from Dr. Jafarov, but his question is also about distraction for hemifacial microsomia. Do you think you want to answer that question, Professor Millesi?
Yeah.
Is saying,
but I'm not doing it primarily. You know,
yeah.
I'm not the one who treats if there is no condyle present. That's not the patient that I see at the primary spot.
Okay, so but I'm not exactly sure what Dr. Jafarov is trying to ask here, because he wrote that from which year is it good for using? So I'm not sure what that means. Is Dr. Jafarov here? Would you like to expand a little bit on your question?
I think it might be the question is what is the best time for the distraction for the hemifacial microsomia patient?
If I would see a patient with asymmetry and vertical deficiency, I see the patient not in the young age. I see the adult one, and in the adult one, I also did distraction already. You achieve a better result, but in vertical aspect, it's always critical because you have the muscle pressure and you cannot achieve what you really want to achieve. And in this case, for example, it was clear that the titanium implant was definitely creating a better aesthetic result in a fast approach, because distraction is a prolonged procedure. So this is, for me, if I can achieve the aesthetic improvement by implant, I would do it with implant.
Yeah, thank you, Professor Millesi. I think that all the patient is come to see you in adult age. Yes. Okay, so thank you very much, Professor Millesi, for your kindly and very considerate to using your phone to have talk by phone with us a whole 90 minutes. Apologize for again the technical error.
No, I'm sorry too. I don't know what is wrong. Actually, I do webinars regularly, so I don't know what has happened. But I'm very glad. I'm thankful that we found a way to do it and that we could do it.
Yeah, finally, I would like to asking you to have a group photo for all the participants in the ICC webinar at this moment. Okay, and we have very nice 4 panelists: Professor Choi from Korea, Professor Wu from the Veteran General Hospital, Professor Clementine and Professor Yao together. Yes, so I will count to 3 and then we can take a group photo. So please show your face and your smile in the screen with us. Yeah, so yeah, okay, Professor Millesi, you can let your hand down. No worry.
Okay. Okay, I will.
Okay, yes. 1, 2. Okay, again. 1, 2, 3, smile. Very nice. I will proceed to the next page. Okay, 1, 2, 3, smile. Okay, thank you. Okay, we finished. Okay, thank you again, Professor.
Thank you very much. Stay safe, everyone. I hope we will meet again in person.
Sure.
I had always very good experience in Taiwan. Very nice people. Yeah.
Thank you.
Thank you very much. Okay.
Okay. Let's say bye-bye. Bye-bye.
Bye-bye.
Thank you. Bye-bye. See you next time.